Okay, in this session we are going to talk about reasons why a colostomy might be done in the adult population. You probably want to follow along on your hard copy document, or so that you can take notes, or you can go onto Blackboard and follow along. Now we're going to start out talking about indications for temporary colostomy, and then at the end we'll talk about indications for permanent colostomy. A very common reason for temporary colostomy is perforation. Perforation can be caused by a number of different things, but we're going to start out by talking about perforation caused by traumatic disruption of the bowel wall. This is most commonly caused by a gunshot wound or a stab wound for those of you in large urban areas like Atlanta. But it can also be caused by seatbelt trauma or other blunt sources of trauma. You think what happens when people are in automobile accidents and the airbag deploys and they're thrown forward and then they're pulled back by their seatbelt. And what can happen is that forward and then reverse motion can cause the bowel to be disconnected from the mesentery. And if you get a disconnection between the mesentery and the bowel, you get rapid development of ischemia, which then results in perforation. We will talk later in this discussion about the fact that in the end, it doesn't matter so much what caused the hole in the bowel wall, the result is the same. So whether it's traumatic disruption of the bowel wall, a ruptured diverticulum, a volvulus, in the end, you have the same results. You have a hole in the bowel, you have stool leaking into the abdominal cavity, you have bacteria leaking into the abdominal cavity, and very rapid development of peritonitis. Now we know that if there's a perforation in the bowel and developing peritonitis, that patient is going to go to surgery and they are always going to remove the damaged section of bowel. The question becomes, what do they do after they remove the damaged section of bowel? Do they reconnect and just close the abdomen? Do they reconnect but then do an ostomy to protect the anastomosis? Do they delay the anastomosis and do an ostomy instead? And that's what we're going to talk through right now. I want to share with you the current level of evidence and standard of care for management of patients who have a perforation in the bowel. We're going to begin with patients in whom normal healing is expected. So that would be hopefully you or me. Let's say you were involved in an accident on your way to work and you did sustain seatbelt trauma, and as a result there was separation between the bowel and the mesentery. You would be developing very rapid ischemic changes in the bowel, and that would result in a perforation in the bowel, spillage of stool and bacteria into the abdominal cavity. You would end up in the operating room. They would always remove the damaged section of bowel. And then what? Well, if it was you or me, and we're healthy, and we have no other major comorbidities, then the standard of care in 2013 is remove the damaged section of bowel, reconnect the two ends of healthy bowel, flush the abdominal cavity, flush the colon, close the abdominal wall, and send the patient to recovery. So let's talk through this in a little bit more detail. Let's say that the hole in the bowel occurs in the sigmoid colon. You're always going to remove the section of bowel with the hole. Here you see they've reconnected the two good ends of the bowel. Now I want to back up and explain something to you about the history involved with this procedure and the change in focus. When I went to what was then known as ET school, the standard of care at that time was, if you had a perforation for any reason, remove the damaged section, do the reconnection as you see here, but at that point in time, we always did a loop colostomy, always. And why was that done? Well, the thinking was this. Stool on the left side of the colon is formed. If formed stool moves through the anastomotic line, before that anastomosis is very well healed, the stretch involved in passage of that solid stool will cause repeat breakdown, will be right back where we started from. So for many years, every patient with a hole in the bowel had the damaged section removed, the ends connected, and a loop colostomy done to protect the anastomosis until it healed. That thinking began to change about 15 years ago when trauma became a major specialty. Trauma surgeons were, in general, working with younger patients, and they started questioning the need to routinely do colostomies to protect that anastomotic line. They pointed out that you could thoroughly flush the abdominal cavity to eliminate stool and to significantly reduce bacterial counts in the abdominal cavity, thus normalizing to a large extent the healing process. They also pointed out that at the time of surgery, when the damaged section was removed, they could flush the colon and they could eliminate retained stool. If at the time of surgery, they flush the colon to remove retained stool and then do the anastomosis, that buys a few extra days before any formed stool moves through the anastomotic line. So they pointed out we can flush the abdominal cavity to help normalize the healing process and to reduce the delay in granulation tissue formation. We can flush the colon to eliminate solid stool so that it will take several more days before any formed stool moves through the anastomotic line. Intestinal anastomoses usually heal well in a healthy individual. Studies have shown that they were exactly right. So studies have been done to compare complication rates in patients who had this procedure, remove the damaged section, flush the colon, re-anastomose, flush the abdominal cavity, close the abdomen. They tracked those complication rates with complication rates in this group of patients where the damaged section was removed, the anastomosis was done, a diverting colostomy was done, abdominal cavity was flushed. And what they found was that the group that were re-anastomosed with no ostomy had better healing outcomes, lower complication rates, because they did not have to go back to surgery. So if you have a patient in whom normal healing is expected, and they have a perforation in the colon, the standard of care in 2013 is to remove the damaged section, flush the colon, do the anastomosis, flush the abdominal cavity, close the abdomen. That's what would happen to you or me. But what if you have a patient where normal healing cannot be expected, where you're almost positive there will be delayed healing? Let me give you an example. A few years ago, I got a call from a friend of mine who's at that time was 48, a nurse practitioner. She said, "You're not going to believe this, I'm in the hospital with a colostomy." Well, what had happened? She had been on high-dose steroids because of a flare-up of her asthmatic bronchitis. She perforated a diverticulum, that's how she got the hole in her bowel. She didn't even know she had that problem. And because she was on high-dose steroids, she only had mild abdominal discomfort. By the time she became significantly ill and went to the emergency department, of course she had massive peritonitis, and she was still on 60 milligrams of prednisone a day. So yes, they did remove the damaged section of bowel. Yes, they did do a reconnection. But they also did a colostomy to protect that anastomosis. because there was no way she would have healed normally. In her case, had they just put her back together, when solid stool moved through the anastomosis, it would not have been healed, and she would have had repeat breakdown and would have started the whole process again. So the group we're going to talk about now is that group of patients. Patients who, for one reason or another, are at significant risk for delayed healing. Maybe they have poorly controlled diabetes. Maybe they're malnourished. Maybe they're on high-dose steroids. Maybe they're on chemotherapy for a malignancy. Maybe they have multiple comorbidities. But when the surgeon looks at that patient, he or she makes the judgment that they are at high risk for impaired healing, and it is not safe to just reconnect and close the abdomen. In that case, the surgeon has two choices. He or she can either go ahead, take out the damaged section, do the anastomosis, and then come up above the level of the anastomosis, either to the colon or the small bowel, and do a protective ostomy to divert the stool until the anastomosis is well healed. Or the surgeon can elect to remove the damaged section but delay the anastomosis. And in that case, they would just go ahead and bring the bowel to the abdominal wall as the stoma would wait until the patient was healthy and stable and would then do the reconnection. So we're going to talk about each of those. So option number one is exactly what we did for many years, okay? Here you're going to go ahead, take out the damaged section, do your anastomosis, but because the patient is at high risk for delayed healing, you're going to protect the anastomosis by creating an alternative route for stool elimination. Now, for many years, if we had an anastomosis at the level of the descending or sigmoid colon, the standard was to do the diversion, the ostomy, at the level of the transverse colon. So many patients came back. They had had a perforation, they had had the sigmoid colon removed, they had had the bowel re-anastomosed, and they came back with a transverse loop colostomy. However, today what you are much more likely to see is exactly the same procedure, removal of the damaged bowel, re-anastomosis, but not a loop colostomy, a loop ileostomy. And let me tell you why. Loop ileostomy is associated with much lower complication rates at the time of takedown than loop colostomy. Why is that? Think about the fact that the large bowel is loaded with bacteria, whereas the small bowel has low bacterial counts. So when they go to do the takedown, if the takedown involves the large bowel, the incidence of surgical site infections, wound dehiscence, etc. is much higher than if the takedown involves the small bowel. If I'm doing takedown of a transverse colostomy, that means that I have to go into the abdomen, separate the stoma from the abdominal wall, remove the section of bowel with the stoma, do an end-to-end anastomosis. But by definition, that will be a dirty procedure because I'm dealing with large bowel. I'm going to have high bacterial counts despite bowel prep and antibiotics. In contrast, if I'm doing takedown of a loop ileostomy, I can make my incision, separate the loop ileostomy from the abdominal wall, remove the little section of bowel with the stoma, do an end-to-end anastomosis, drop it back into the abdominal cavity, and it's a relatively clean procedure with low bacterial counts and lower complication rates. So wherever you are in 2013, you're probably going to find that your surgeons are using loop ileostomy to protect an anastomosis anywhere in the colon, as opposed to loop colostomy. Now there's another option. Option number one, as we've already discussed, is going and do your reconnection, but protect that anastomosis with a proximal stoma that keeps stool away from the area while the area heals. We've discussed the fact that in 2013, the standard is to do loop ileostomy, not loop colostomy. Option number 2, you've removed the damaged section. You could elect to delay the anastomosis and to bring the proximal bowel to the abdominal wall as a colostomy, and to wait until the infection has been resolved, until all comorbidities have been addressed, until the patient's in a very good position to heal, and then to bring the patient back for that reconnection. Now, what are you going to do with the distal bowel in the meantime? Well, most commonly they do a Hartman's pouch. This actually was named after Dr. Henry Hartman, a British surgeon, and he was the first one to think, you know what, we could bring the proximal stoma to the abdominal wall. We could staple or suture that distal segment shut and just leave it in the pelvis or in the abdominal cavity. And then, once the patient's healthy, the infection's resolved, we're ready to do the reconnection, we can go back in, disconnect the colon from the abdominal wall, remove this little section with the stoma, remove this little section with the staples or sutures, hook these two ends together. So then you've reestablished normal bowel function. So colostomy with Hartman's pouch, the patient comes back with a colostomy. Once everything is healed, once the patient's healthy, they come back to surgery again, and the bowel is reconnected and bowel function goes back to normal. There is one other option. Here you see Hartman's pouch. The surgeon might elect, in certain situations, to bring both ends of the bowel to the abdominal wall. And then they just sit there. And the proximal bowel drains stool, and the distal bowel drains only mucus, and is therefore frequently known as a mucus fistula. And then, once all comorbidities have been addressed, all the infection's been resolved, they can disconnect each of these from the abdominal wall, remove the section with the stoma, and hook the two ends together. That's not as commonly done in the adult population. It's fairly commonly done in the pediatric population. So what I want you to think of is basically 3 scenarios. Scenario number 1, healthy patient, hole in the bowel. You're going to remove the damaged section, flush the colon, sew the two good ends together, flush the abdominal cavity, close the abdominal wall, no stoma. You won't see that patient. Scenario number 2, patient at risk for delayed healing. You're going to remove the damaged section. You're going to go in and do your reconnection. You're going to do the anastomosis. You're going to then do a loop ileostomy to protect that anastomosis until it's well healed, at which point you'll close the loop ileostomy. Option number 3 also involves a patient at risk for delayed healing. Remove the damaged section. Do not do an anastomosis. Bring the proximal end of the bowel to the abdominal wall as a colostomy. Either leave the distal end closed as a Hartman's pouch, or bring the distal end to the abdominal surface as a stoma as well. Once all comorbidities have been addressed, all abdominal infection has been resolved, trim the two ends of the bowel and reconnect. Now, most of the time, as you see on your handout, the takedown of any ostomy is done about 8 to 12 weeks following the initial procedure, but it's extremely variable. If the patient's doing well, the surgeon might close as early as 6 weeks post-op. If the patient has many things going on, closure can be delayed for many months. As you probably already know, in some situations we're never able to do takedown just because the patient's too unstable because of other issues, cardiac issues, whatever. Okay, now we're going to go to the second reason why a patient might have a temporary colostomy. This is a much less common reason. I don't want you to spend a lot of time on this. I want you to have a basic understanding. We're not going to test you very much on this. Go back to What does it mean if I say that there is a section of bowel that is atonic or hypotonic? Well, tone refers to muscle tone and to motility. And we know that normal colon function is totally dependent on normal peristalsis because you have to move stool through the colon. We also know that in order for muscles to function normally, they have to be innervated because it's nerves that tell muscles what to do. So when we say that you have a patient with an atonic bowel with congenital or acquired megacolon, what we're saying is that you have a colon that doesn't work, that there are sections of the colon that have diminished or absent peristalsis, and that the alteration in peristaltic activity is due to absence or damage to the nerves that innervate the muscles of the gut. Now, most commonly, we see this in children. You might have heard the term Hirschsprung's disease, and we're going to talk about this later in our class on fecal diversions in children. Hirschsprung's disease is congenital megacolon. Now, what happens with Hirschsprung's disease is that there is a failure of innervation. During fetal development, innervation occurs proximal to distal. What does that mean? It means that first the mouth and esophagus and stomach are innervated, and then the small bowel is innervated, and then the ascending colon, and then transverse, and then descending, and then sigmoid, and then rectum, and then sphincters. Because innervation occurs proximal to distal, if there's any failure in innervation, it's always going to involve the distal bowel. The section without normal innervation loses motility, loses function, collapses down, and then as a result of that non-functional section, everything above that point distends, dilates, hypertrophies, trying to compensate and push through that little damaged section. That's what happens with congenital. So let me just show you this. Of course, we know that the bowel is very richly innervated normally. We talked about this in A&P, that we have all these nerve plexuses between the muscle layers, and then we have little nerve cells in the lumen of the bowel responding to both local signals and responding to what's going on in the body through the autonomic nervous system. So we know that normal function is characterized by 2 layers of muscles and multiple nerve plexuses. Now, this just shows you what happens with congenital megacolon, where the very distal end of the bowel did not get nerve cells. Okay, so this little section here, the internal sphincter of the rectum, and the very last part of the sigmoid are not innervated normally. So this little section is no longer helping to push stool through. Instead, it's kind of collapsed down like a closed pipe. As a result, everything above that point distends, dilates, hypertrophies, trying to compensate and push things through. If you saw this x-ray, you would first think that this was the damaged or dysfunctional section of the bowel. Actually, this is the healthy section trying to compensate for this section, which is the section that has no nerve endings. Now, we were talking about congenital, and we said that the distal rectum and internal sphincter were always affected. Go back to what the internal sphincter does and how it works. It provides continence at rest, so that means that it's normally contracted. But in response to rectal distension, it relaxes and opens the anal canal to allow stool to pass through. So here's normal function. The rectum's distended, internal sphincter opens, stool is passing through. Abnormal function. Rectum's very distended, internal sphincter does not open, and stool is trapped in the rectum. This just shows you again that variable lengths of bowel can be involved in that congenital megacolon. Now, right now, I don't want you to focus on congenital megacolon at all. We're going to come back to that when we talk about fecal diversions in children. I just wanted to mention within the big picture of megacolon There's two different types: congenital, which we see always in the pediatric population if we're going to see it, and acquired. And now we're going to move over to acquired. Now, within the category of acquired megacolon, there's two distinct patterns. The first is toxic megacolon. This is actually a complication of chronic ulcerative colitis. You might occasionally see this associated with C. diff, but it's more commonly associated with ulcerative colitis. And what happens with toxic megacolon is you have an acute exacerbation of the underlying inflammatory process. The acute exacerbation involves the nerve plexuses and causes damage to the nerve plexuses. That shuts down peristalsis to that section of bowel. When you shut down peristalsis to that section of bowel, the proximal bowel rapidly distends and dilates. Now remember, this is a complication of an inflammatory process. So not only do you have a rapidly distending section of bowel, but it's a very inflamed section of bowel. That combination can result in early perforation. These patients typically are very, very ill. They're febrile, they might be shocky, they're very distended, and they're very high risk for early perforation. So I want to just show you on these slides basically what happens. So typically you get involvement right in here, rectosigmoid, so you shut down the nerve pathways, you damage the nerve cells, that stops peristalsis, this section of bowel kind of just shuts down. The proximal bowel rapidly distends, and you can get early perforation. As we've mentioned here, you actually see the colon at the time of surgery. This patient had impending perforation and required emergency colectomy and ileostomy. So that's toxic megacolon. Now there's another type of acquired megacolon, and we don't really know exactly what happens here. These are patients who, for many years, had fairly normal bowel function and then develop very severe constipation that is not responsive to simple measures like fiber and fluids and things like that. And if you do studies on these patients, you'll find that there are sections of the colon that just aren't working. And the theory is that there has been damage to the nerve cells in the colon wall, either as a result of an autoimmune process or a viral illness or whatever. So with toxic megacolon, rapid development of this acute syndrome, very, very sick patient to the operating room in almost all cases. Whereas with a viral or autoimmune disorder, you get a progressively severe constipation due to progressive damage to the nerve cells in the bowel wall. Okay, so what about workup and treatment? And again, I just want you to think of this kind of in broad terms. I'm not going to ask you a lot of questions. This is not your major focus at this point. But if you have a patient who comes in with toxic megacolon, they're really, really sick. It's obvious that they're acutely ill. Usually, it's pretty obvious that they're going to need surgery. They might do just a plain abdominal x-ray, which will demonstrate the rapid distension of the proximal bowel. Treatment will involve steroids, antibiotics, and almost always surgery. Okay. If you have a patient who presents with progressively more severe constipation, very poor response to fiber and fluids and laxatives, then typically they're going to end up doing initially just a plain x-ray that's likely to show sections of the colon that are very distended and might show sections that are kind of collapsed down, the sections that aren't working. Many times they will do a motility study, and what they do when they do a motility study is they first of all have the patient stop all laxatives, because anyone with chronic constipation is typically on laxatives. They'll tell them stop laxatives, which is very hard for that patient. And then after a period of 3 to 5 days, they'll give them a capsule called a sense marker capsule, and it's just a little gelatin capsule with radiopaque rings. And then 5 days later, they'll do a plain x-ray of the abdomen, and they're looking to see, so have all of those radiopaque rings moved over to the descending sigmoid, and are they passing through? Or do we have a lot of the radiopaque rings concentrated on the ascending colon, in the ascending colon, suggesting a problem at the level of the transverse? It just helps to document that, yes, there's a major problem with motility. Sometimes we're able to manage those patients medically with a variety of laxatives and stool softeners, but other times if they have very, very severe constipation, we might have to remove the section of bowel that's just not working. I have occasionally had patients who had to have removal of the entire colon and ended up with an ileostomy or with an ileorectal anastomosis. Now again, I just want you to basically understand the concept of megacolon, massive distension of the colon. Why would you have distension of the colon? Because there's a section that's not working. Why is it not working? Either because there's congenital absence of the nerve cells in that area, Hirschsprung's, that we'll talk about later, or because you have a patient with severe ulcerative colitis and toxic megacolon that's knocked out the nerve cells in that section, or in a patient with progressively severe constipation, an autoimmune or viral process. Okay, let's talk about diverticular disease, one of the most common reasons for a temporary colostomy. So wherever you are, you're going to see patients with diverticular disease, complications of diverticular disease, and ostomies related to diverticular disease. So first of all, what is diverticular disease? And I think you already know this. It's where you form these little sacs along the colon wall. Specifically, what happens is you get into a situation where you have very high pressures within the lumen of the bowel that are pushing against the bowel wall. So on the inside, I'm pushing against the bowel wall. Now, you have little areas of weakness in the bowel wall because at multiple points along the lumen of the bowel, you have these little nutrient blood vessels that penetrate the muscle layer in order to nourish the mucosa, the submucosa, to support water reabsorption, electrolyte reabsorption, etc. These are small blood vessels, but nonetheless, at every point where a blood vessel penetrates the bowel wall, you have a small gap in the muscle. And that small gap is a potential weak area. So if you have small gaps in the muscle layer surrounding the lumen of the bowel, and then you have very high pressures within the lumen of the bowel, you can get these little sacs or little blowouts forming right along those blood vessels. Now what happens, here's the muscle layer, here's the serosa. Notice that it's the mucosa and submucosa that herniate through the muscle and serosal layer. So this is a very thin-walled sac, and that's one reason that they perforate so easily. Also, whenever you form these sacs, now it's like having multiple appendices, and so you're very high risk for inflammation to develop involving these sacs, and that's exactly what diverticulitis is. Now notice on your handout, it says that diverticular sacs are much more likely to form along the left colon. Well, that makes sense because stool on the left side of the colon is solid, and it's going to take higher pressures to move that solid stool through than if the stool was liquid or mushy. So we understand that. Some people call it left-sided appendicitis. The other thing you see is that this disease process is pretty much unique to Western civilization and is thought to be due in large part to ingestion of a low-fiber diet. So I wanted to explain the link between a low-fiber diet, development of diverticular disease. If you were on a high-fiber diet, let's start with normal bowel health, normal function. So normal function is dependent on adequate fiber and fluid intake, which will produce soft, bulky stools that keep the colon kind of stretched out to its normal diameter, because the stools are soft and bulky. It doesn't require a lot of pressure to push the stool through the colon. In fact, normal pressures within the colon are generally considered to be less than 10 millimeters of mercury to push stool through a normal colon. Now let's take someone who's not getting enough fiber, not getting enough fluid. Their stools are going to be narrow caliber and much drier, and it's going to take much greater propulsive force to move that stool through the colon. So what happens is, number one, the colon kind of collapses down around these narrow stools. So now you have a narrow pathway and you're trying to force this dry, sticky stool through this narrow pathway. That takes a lot more pressure. Pressures within the colon among patients with diverticular disease have been measured at over, as you see, 90 millimeters of mercury. Contrast that to the normal levels of less than 10. So marked increase in intraluminal pressures. That's what creates the little sacs. Now the other thing that happens is the muscles of the colon wall are working really hard trying to squeeze this dry, narrow stool through, and they become hypertrophic, which contributes to the high pressures and also helps to narrow the lumen. And then there's some thinking that there may be some kind of inherent motility disorder, but the primary focus is on the impact of low fiber diets and the resultant impact on intraluminal pressures and muscle function. So that's what we're going to focus on. Now, diverticular disease occurs in three distinct phases. You've got pre-diverticular disease, diverticulosis, and diverticulitis. Pre-diverticular disease means you don't have any sacs. Your colon still looks healthy. If you did a barium enema, you would see nothing. If you did a colonoscopy, you would see nothing. But if you did a pressure measurement, you would find that the intraluminal pressures were elevated, that already the colon is working harder to push stool through. And you would know that those high pressures are increasing the risk that these sacs will form. The problem with pre-diverticular disease, nobody knows they have it, because we don't go around routinely doing pressure measurements within the lumen of the colon. So we can't identify people with pre-diverticular disease, but we can educate people in general about bowel health. We can talk about the importance of fluids. We can talk about the importance of fiber. We can talk about perfect poop. So we don't talk about this a lot, but we probably should talk about it more. What is perfect poop? Well, perfect poop is like a smooth sausage. All the stool is massed together. You don't have any little solo travelers, no little pellets. Okay, you've got bulk, but it's not hard. There's actually a Bristol stool consistency chart, and that sits right in the middle of the chart because that represents normal. That's what you get when your bowel is working normally. You're taking in adequate fiber and adequate fluid. The advantage of educating people about fiber, fluid, and perfect poop is that they can kind of monitor their own bowel function and know if they're at risk for problems. Here's the other thing, so they can check, do I have smooth sausage or do I have pellets? The other thing is when you're getting enough fiber and fluid, your stool tends to float. So you want floating sausage, you don't want sinkers, okay, and you don't want pellets. Okay, so no solo travelers, no sinkers. Smooth, floating sausage. Okay. Diverticulosis. Now the sacs have formed. So you see how the sac is formed here? And once the sac has formed, you can't undo it. So once you develop the sacs, now you are at risk for diverticulitis. Now the good thing about diverticulosis is that at this point the sacs are not inflamed. Our goal is to keep it that way. How do we keep it that way? Well, inflammation occurs when you get little bits of stool trapped in this sac. Because as you can see, the sacs have a narrow opening, then they open up. So that's why we said we don't want any little pieces to go through. Okay, we want normal stool. We seriously want smooth sausage. We do not want to see pellets because pellets increase the risk of diverticulitis. What should we tell patients who know they have diverticulosis? Because we can diagnose diverticulosis from a barium minima, from a colonoscopy. We should really emphasize the importance of fiber and fluid. Some clinicians will tell them not to eat seeds. Now, there are several things you need to know about this recommendation. First of all, there's no evidence behind it. But where they're coming from is they're thinking, well, you know, what if a seed got caught up in that little sac? That could trigger an inflammatory process. So that brings us to the second thing, and that is they're not talking about the little tiny seeds like you get on strawberries or in squash or in tomatoes or cucumbers, because that's what patients think. They're talking about large seeds that people eat as snacks, like pumpkin seeds or sunflower seeds. So you want to tell patients, don't worry about those little tiny seeds, that's not what they're talking about. Point number 3, the most important aspect is maintaining soft, bulky stool, no solo travelers, no little pellets. This is what you want to avoid because little pellets can get caught out in the sac and trigger the inflammatory process. Once you get inflammation, you have diverticulitis. Here's the pathology of diverticulitis, essentially the same as for appendicitis. You get a little bit of stool trapped out in the sac. Now remember, the sac's lined with mucosa, so the mucosa is going to continue to absorb liquid from the stool, and so it's going to turn that little bit of stool into what they call a fecal stone, a fecalith. Then that dried stool will abrade the mucosa and create little injuries along the mucosal wall, and that allows the bacteria to penetrate. Now you have a full-blown inflammatory process involving a very thin-walled sac. And one of two things can happen. You can have microperforations and abscess formation that can kind of wall off, or you can have free perforation. Here you can see the inflammatory process. So here, what's happening is you're getting like little microperforations, but it's being walled off, and it's not, you don't have free perforation out into the abdominal cavity. But if you get free perforation, then it's going to be draining stool and bacteria out into the abdominal cavity, and that's going to force surgical intervention. So let's say you have free perforation and the patient's going to surgery. What are the surgical options? And I want you to realize this is exactly what we've already talked about, because again, you have a hole in the bowel. We talked before about a hole in the bowel caused by gunshot wound, stab wound, seatbelt trauma. Now we're talking about a hole in the bowel caused by perforation of the diverticulum. But in the end, whatever caused the hole in the bowel, the end result is the same. Stool leaking into the abdominal cavity, bacteria leaking into the abdominal cavity. So, if you have a patient who comes in with a ruptured diverticulum, but other than that, that patient's very healthy, they're well nourished, they have no significant comorbidities, they're non-diabetic, or their glucose levels are well controlled, they're not on steroids. They're going to remove the damaged section, they're going to flush the colon, they're going to do an end-to-end anastomosis, they're going to irrigate the abdominal cavity, and they're going to close the abdomen. Okay? That's what you see here, what we've already talked about. In contrast, back to my friend, high-dose steroids and very, very advanced peritonitis. Definitely high risk for delayed healing. No way they were just going to put her back together. So when you have a patient at risk for delayed healing, you have a couple of options. One, you can take out the damaged section, do your end-to-end anastomosis, and then do a loop ileostomy to protect the anastomosis. Wait till the anastomosis is very well healed. All comorbidities have been addressed, and then close the ileostomy. Or, second option for the patient with delayed healing for whatever reason, take out the damaged section, bring the proximal bowel to the abdominal wall as a stoma, so the stool drains out here. I tell the patients, you know, we've got to let everything heal up. We've got to get the infection under control. Till we do that, we're going to create a detour for the stool. Once we get everything under control, your doctor can go back in there and put you back together. But right now, we're creating a detour. So here's your detour. And then for adults, typically they'll do the Hartman's pouch where the distal end is sewn shut and left in the pelvis. Once the patient's stable, comorbidities have been addressed, intra-abdominal infections resolved, they'll disconnect the stoma from the abdominal wall, remove the little section with the stoma, remove the little section with the staples, and put them together. Now you're fixing to hear the same thing a third time, so I'm hoping that you're starting to see that in the end, it's not so much how you got the hole, it's dealing with the outcomes, and that whether that hole in the bowel was caused by trauma, by ruptured diverticulum, by volvulus, management's going to be essentially the same. So let's talk about volvulus. Volvulus can occur in children, it can occur in adults. What happens with volvulus is literally the bowel twists on itself. Both the bowel and the mesentery twist. Now this sets up a very serious condition because you have what we call a closed loop obstruction. The bowel is twisted here and here, closed here, closed here. So that means you have a section of bowel, you don't get proximal drainage, you don't get distal drainage. But the glands in the bowel wall are going to continue to produce fluid, and the bacteria are going to continue to produce gas, so the bowel, that loop of bowel will distend rapidly. At the same time, the kink in the mesentery causes loss of blood flow to the abdominal wall, so you have rapidly progressing ischemia, necrosis. So now you have a loop of bowel that is becoming progressively more ischemic, moving into necrosis, and it's rapidly distending, and the end result is early perforation. Now these patients end up in the operating room very quickly because it is obvious to everyone who sees them that they have an acute abdomen and that whatever is going on in there, they have to go to surgery because they go from being fine one minute to being in excruciating pain the next, rapidly developing abdominal distension, rapid development of shock because they're in so much pain. Sometimes they might do a flat x-ray, most of the time they just take them to surgery. Okay, now this shows you this loop of bowel that is rapidly distending and becoming progressively ischemic, and this shows you an actual bowel at surgery. And look how massive the distension is. There's already perforation, and you can see the bowel is very dusky because of the twist in the mesentery. Now, most commonly, especially in adults, this involves the sigmoid colon because in a lot of adults, or I shouldn't say a lot, in some adults, the sigmoid colon is a longer section. They sometimes refer to it as a redundant sigmoid colon. And the mesentery in that area is frequently very mobile, which allows for greater mobility of the sigmoid colon and increased risk that it will twist. Okay, so now let's talk about how they're going to manage. The patient's going to be in the operating room very quickly. Now again, if you have someone who has essentially no comorbidities, no other issues, they've just got this volvulus out of nowhere, they get them in there, they can take out the damaged section, do the end-to-end anastomosis, flush the colon, I forgot to mention. Take out the damaged section, flush the colon, do your end-to-end anastomosis, flush the abdomen, and close them up. But many times these patients do have other comorbidities. So many times you're dealing with the risk of delayed healing, and it's going right back to what we've already said, because you've got a hole in the bowel. So you're going to take out the damaged section, do your reconnection, but come up the line and do a loop ileostomy to protect. Give it plenty of time to heal, get the patient stable, get all comorbidities under control, close your loop ileostomy. Or take out the damaged section, bring the proximal valve to the abdominal wall as a colostomy, close the distal section, leave it in the pelvis or abdomen as a Hartmann's pouch. Get everything under control, stabilize the patient, normalize healing, bring the patient back, disconnect the colostomy from the abdominal wall, cut off this little section, cut off this little piece, put them together. Now, I mentioned that children sometimes develop volvulus, and in the pediatric population, they're much more likely to do the colostomy with the mucus fistula. Just bring both ends of the bowel out to the abdominal wall so they can watch them, and then they put them back together once everything's stable. So I hope you're starting to see a hole in the bowel, for whatever reason, is going to follow the same surgical path. Another potential reason for a temporary colostomy is severe inflammation, typically involving the distal colon and the rectum. You're most likely to see this in patients with severe Crohn's disease, maybe occasionally patients with very severe C. diff colitis. But here the problem is you have a patient who has very severe inflammation in the distal bowel. You've been trying to treat them, but you can't get the inflammation under control because stool keeps going through there. With Crohn's disease, one of the things that can happen is you can get severe perirectal disease. We'll talk more about this later in this module. But perirectal disease involves formation of little fistula tracts off of the rectum and the anal canal, tracking out to the perineum. Now, the stool is typically too formed to go through those little narrow tracts, so they're not typically draining stool out onto the perineum. But the problem is these tracts are full of bacteria, so they're cranking out all this malodorous fluid all the time. So they have a lot of malodorous drainage, they have a lot of tenderness and pain, it hurts to sit. For women, sex is very painful, it's miserable. They're worried about odor, they're worried about drainage. Sitting is miserable, sex is miserable. But it's a benign process. So you're thinking, the surgeon is thinking, well, you know what? If we could bypass that area and just rest it for a period of time and get all those little fistula tracts to close up and get the inflammation under control, maybe once we get everything under control, maybe we can hook you back together. So in this situation, when you have very severe inflammation involving, say, the rectum or maybe the rectum and the distal sigmoid, what they can do is divide the bowel, bring the proximal bowel out as a descending or sigmoid colostomy, do a Hartmann's pouch. And the goal here is simply detour the stool. Let's see if we can get that inflammation under control. If we can get that inflammation under control, get all those little fistula tracts to heal up, then we can reconnect you and hopefully it won't recur. Sometimes it does, and then they usually end up with a permanent colostomy, but many times that temporary colostomy does exactly what they hope it will do. It allows them to get closure of all that, those perirectal tracts and fistulas, and when they reconnect them, hopefully they will continue to have good outcomes. If it continues to recur, then they'll end up with a permanent. Okay, and then the last reason for temporary colostomy is obstruction. So you could have an obstructing lesion at any point along the colon, but most commonly obstructing lesions occur at the level of the rectum or the sigmoid. And most commonly they're due to malignancy. So you have a sigmoid tumor, you have a rectal tumor that causes progressive obstruction of the lumen of the bowel. And it can progress to the point where nothing is going through. And then you get massive distension of the proximal bowel in a very sick patient. And people always ask, well, why didn't that patient come in sooner? Well, I'll tell you a couple of patients I had. One patient who did not come in until he was completely obstructed. He had a sigmoid cancer, didn't come in until he was completely obstructed, knew he had a problem, had progressive problems with constipation, just kept taking higher and higher and higher doses of laxatives to keep his stool thin so it would go through. Came in when nothing was working anymore. Why did he wait? Because he was the sole support for his family, because he did not have insurance, because he didn't have sick time. So if he didn't work, he was worried that his family wouldn't eat or they would be evicted. Powerful motivation for keep on going. So you can have patients who come in with essential complete obstruction and then massive distension of the bowel above that point. Now, we've already said that most commonly your obstructive lesions occur somewhere in here. So the most common procedure is to do a loop colostomy just above the tumor. So if it's obstructed at the level of the sigmoid, you typically do your loop colostomy at the level of the descending colon or possibly the transverse colon. So anytime you have an obstructing lesion, your first goal is always to decompress. You can't do anything else until you decompress the bowel, eliminate the obstruction, do a workup. So I'll tell you about another patient I had. He came in and he was almost completely obstructed. He was very distended. He was losing weight because he hadn't been able to eat very much because nothing was going through. It was obvious that he had a lesion in the sigmoid colon, but his colon was so full of stool we couldn't do anything in terms of workup or management. So they took him to surgery. They did a descending loop colostomy. Then we got the bowel cleaned out over the next week. The bowel decompressed. His abdominal distension started to resolve. Once we got him stable post-op, got him effectively decompressed, then they did a workup. They found that even though he had a sigmoid tumor that was essentially obstructing, completely blocking the lumen of the bowel, he had no distant mets. And so they were able to go back in. They were able to resect the entire left side of the colon and to connect the transverse colon to the rectum. Wait a minute. Transverse colon to the anal canal. So they actually took out everything from the transverse colon down to the anal canal, connected the transverse colon to the anal canal, did radiation chemotherapy, and he did well. So sometimes when patients come in and they have an obstructing malignancy, we kind of assume, well, that's it. That's not always true. So your goal number one, somebody comes in obstructed, restore output, okay? Restore stool elimination, decompress the bowel, then figure out what's going on with the obstructing lesion and treat the obstructing lesion. So bowel obstruction, another reason for doing a temporary colostomy. Now let's talk about permanent colostomies. By far the most common reason for a permanent colostomy is cancer of the distal rectum. And I emphasize distal rectum, that's actually a change. For many years, the guidance in terms of doing curative resection for rectal cancer was to take out the tumor, take out 5 centimeters or 2 inches above the tumor, take out 5 centimeters or 2 inches below the tumor, send it to pathology to verify clear margins. When you think about the fact that the rectum itself is about 5 inches long, that meant that almost all patients with rectal cancer ended up with removal of the entire rectum, anal canal, sphincters, and a permanent colostomy. Well, then they went, some wonderful group went back and reviewed hundreds of thousands of pathology reports. And they realized that for some reason, and I don't understand why, but for some reason, cancer cells, rectal cancer cells, will migrate further proximally than they will distally. So they did find that cancer cells migrated as far as 5 centimeters proximal to the tumor, but that they very rarely migrated more than 1 to 2 centimeters distal to the tumor. That changed the guidelines for curative resection for rectal cancer. And in 2013, the guidelines for curative resection are take the tumor, take at least 5 centimeters above the level of the tumor, have pathology verify clear margins. Take at least 1 centimeter below the tumor and have pathology verify clear margins. Now here's what dictates whether or not a patient has a permanent colostomy. It all comes back to exactly where the tumor is. So if you had a tumor that was, say, located more proximal in the rectum, then let's say it's right in here, then they could take 5 centimeters above, they could take 1 centimeter below, 1 to 2 centimeters below, and they would still be above the level of the sphincters. So if they took from here to here, and pathology verifies clear margins proximally, clear margins distally, that would be great because the sphincters have been preserved and you could do a reconnection. We'll talk more about that in just a minute. Right now, I want you to focus on this scenario. Look at this tumor. See how it's located very, very low in the rectum? The problem is, by the time you take 5 centimeters above, 1 to 2 centimeters below, you'll be past the sphincters. You're out into the anal canal. So if you have to go past the sphincters to get clear margins, you cannot do a reconnection because you would be connecting colon to perineum. The patient would lose all control and would have constant fecal incontinence. And of course, we would never do that to anyone. So here's what would be done. When you have a very low-lying rectal tumor and when curative resection takes you past the sphincters, then they're going to take out the entire rectum, the anal canal, the sphincters, the anus. You're going to have a perineal incision and you're going to have a permanent colostomy. So distal rectal cancer, low rectal cancer, in order to get a curative resection, you have to go past the sphincters. That means you cannot reconnect. That means the colostomy will be permanent. This procedure is known as abdominal perineal resection. You see that on your handout. I want you to learn that term because when you see that term, if you see on a surgical report that the patient had APR for rectal cancer, that tells you that there was an abdominal incision, that there was a perineal incision in order to remove the rectum, the anal canal, and the sphincters. And it also tells you that that colostomy is permanent. So APR, abdominal perineal resection of the rectum. Now let's go back to patients who have tumors that are located further away from the anal rectal margin, further away from the sphincters. Let's go back to patients who have cancers located in the mid-rectum or the proximal rectum. The advantage here is that if your tumor is located, say, right in here, that you can take out plenty of tissue proximal to the tumor. You can take out 1 to 2 centimeters distal to the tumor, establish clear margins, and still retain the sphincters. So the section in gray is the section that has to be removed to get clear margins. You see how the anus, anal canal, and sphincters remain intact. That gives you the option to then mobilize the proximal colon and connect the colon to the anal canal. So here, you can remove the tumor, remove the rectum, and then do coloanal anastomosis. Now, two different things could happen. Let me first tell you that this procedure is known as a low anterior resection. Because all the work is done through the abdominal incision, you're working low in the pelvis, but you're doing everything through the anterior or abdominal incision. Okay? So when you see the term LAR, it tells you that the tumor was either mid-rectal or proximal rectal, that they removed the rectum, but they mobilized the colon and connected it to the anal canal. Now, when you connect the colon to the anal canal, it all depends on the mobility of the colon and the mesentery, because you've got to pull the colon and mesentery down to do the anastomosis to the anal canal. You certainly can't pull the anus up. It's not going, okay? So the colon has to come down. If the surgeon does the anastomosis and feels really good about the anastomosis, it's like, I've got a very strong anastomotic line. The anastomosis is not under tension. I've got a basically healthy patient. I think they're going to heal this anastomosis quickly. Then no stoma would be needed. But what if the surgeon took out the rectum, mobilized the proximal colon, got it down, did the anastomosis, but it's under a lot of tension. And the surgeon's like, it's going to take longer to heal that because there's tension on the anastomosis. Then what the surgeon would do was he would come up the line, or she would come up the line and do a loop ileostomy. What this translates into, if your patient has had a low anterior resection, by definition, that means the rectum has been removed, the anal canal, sphincters, and anus have been preserved, the colon has been connected to the anal canal, and if an ostomy was done, it is to provide temporary protection while that anastomosis heals. So with low anterior resection, if it's easy to do this anastomosis with no tension, no stoma. If the anastomosis is under tension, temporary stoma. But you would not have a permanent stoma with a low anterior resection. Why would you? Your sphincters are intact. Now, one thing, if you get to talk to these patients, you should just mention to them is that when we remove the rectum, we remove the reservoir that normally stores stool for us when we have to go, but it's not convenient. Because we have the rectum, it allows us to delay defecation until we can get to the bathroom. But in this case, we've removed the rectum and we've connected the colon directly to the anal canal, so that patient's lost their reservoir. Now, over the first 3 to 6 months post-op, gradually the sigmoid colon or the descending will distend and form a little bit of a pouch to provide storage for stool, temporary storage for stool. But it takes 3 to 6 months for that to happen. And in the meantime, these patients can experience intense fecal urgency and frequency. So I tell patients, don't go out to a restaurant until you know what to expect. Some patients, after they eat, they might have a series of 4 to 6 bowel movements over the next 15 to 20 minutes because of peristalsis stimulated by eating and lack of a storage area. If they have that intense urge to go on the way home from the restaurant, they're not going to be able to hold it because they do not have a storage area initially. So you don't want them to have embarrassing incontinent episodes. You just want to alert them to the fact that their reservoir has been removed. It's going to take 3 to 6 months for the body to create a new one. They need to pay attention to their patterns of stool elimination and then modify their lifestyle accordingly. Now, some surgeons, if the proximal bowel is very mobile, they will double it back on itself, sew it together, open it up on the inside to create a little bit of a reservoir. that's done simply to improve quality of life the first 3 to 6 months is called a coloanal J pouch. It's not routinely done. I'm not going to ask you about that. It will not be on the test, but I just wanted to mention it because you might have surgeons who are doing it, and it certainly can improve quality of life for your patients. Okay, so the last thing I wanted to go over, just a few more things, and then we're going to take a break before we move ahead to management of the patient with the colostomy. I want you to look very carefully at this section in your module where we go through the surgical procedures. It's absolutely critical for you to be very clear on what each of these procedures involves, what the definitions are, what the implications are. So let's first talk about loop versus end colostomy. Now, with the loop colostomy, as you can see, you've made an opening in the abdominal wall. You have not divided the bowel. Instead, you've reached in, you've brought out the entire loop of bowel. So here you can see you made the opening in the abdominal wall, you brought out the entire loop of bowel. So it comes up, out, down, and keeps going. Then, once you get the loop of bowel brought out, it's stabilized on the abdominal wall, usually with a little plastic bridge or bar, or with a red rubber catheter. We're going to talk more about that, but also by sutures, because here you have your cut opening in the abdominal wall, the loop of bowel brought through that. What they're going to do next is they're going to make an incision in the anterior wall of the bowel only. So you have a hollow structure. You're going to make an incision in the front of the bowel. The back wall remains continuous. Once you make that incision, then you're going to turn the bowel back on itself and suture it down. When you do that, the back wall of the bowel, the front wall is open. The back wall pulls forward and creates separation between the proximal and the distal bowel. So you end up with one stoma to pouch, 2 openings. And you see that here and here. And I wanted to show you, and then we'll talk more about it when you come on site as well. So if you're doing a loop ostomy, you bring the entire loop of bowel to the abdominal wall. So you've made an incision, you've brought out the entire loop of bowel. But you see, you have not divided the bowel, it's continuous. So here's the bowel going one way in the abdominal cavity, you've brought it out to the surface, here it is going the other way. So it just comes up, goes back in. You're going to make an incision in the front wall of the bowel, but the back wall is not divided. The back wall is continuous. Then you're going to turn the bowel back on itself. This is called surgically maturing the stoma. This now allows me to suture it down. So I've turned it back on itself. I'm going to suture it down to the abdominal wall, just like you see here. Now what I'm going to end up with, here's my loop of bowel coming up onto the abdominal wall, going back in. You end up with one stoma. You end up with access to the distal and access to the proximal bowel. And why is that? Because this back wall, when you open the front wall, the back wall pulls forward and creates separation. And we'll talk more about this when you come on site. But I want you to know with a loop ileostomy, the bowel is not divided. The entire loop of bowel is brought to the abdominal wall. The anterior wall is opened. The bowel is turned back on itself. You end up with one stoma, 2 openings. In contrast, with an end stoma, the bowel has been divided. So you see in each of these, the bowel has been divided. This is now the end of the bowel. You turn that end back on itself. Again, surgically maturing the stoma, and suture this to the abdominal wall. Suture it to the dermis. Okay? When you mature it, when you turn it back on itself, now you've exposed the mucosa. And the mucosa keeps itself moist. We'll go over that again. Now, if you come to a patient's room and you find that they have an end stomach, you don't really know what's happened to the rest of the bowel until you go and read the surgical report. That's why it's always critical to read the surgical report, and if there's something we don't understand, to talk to the surgeon to make sure we understand what has been done to that patient and what the plans are for that patient. When I have an end stoma, it could mean this. It could mean that everything below that point's been removed. That's what it would mean if the patient had had an APR, abdominal perineal resection of the rectum. So if I see this end stoma, and then I go to the chart and I see that the patient's had an APR, I know that this is a permanent colostomy. Everything below this point's gone. But I could also see an end stoma in a patient with a Hartmann's pouch. Again, Hartmann's pouch now tells me something totally different. Still have my end stoma, but it tells me that the distal rectum, anal canal, and sphincter are intact, and that long-term the goal is to reconnect this patient. So you can see that the implications for patient teaching, for counseling, for answering questions would be totally different in managing a patient with a sigmoid colostomy and Hartmann's pouch versus sigmoid colostomy and APR. So you always read that chart, read that surgical note. We've already talked about how important it is to be clear on APR versus LAR, abdominal perineal resection, both an abdominal incision, a perineal incision, removal of the rectum, anal canal, sphincters, permanent colostomy, versus LAR, low anterior resection, where you're taking out the rectum all the way down to just above the sphincters. You've connected the colon to the anal canal. The anal canal, sphincters, and anus remain intact. There's no perineal incision, only an abdominal incision. There might be an ostomy, but it would be temporary and it would be done just to protect the anastomosis until it was well healed. Also notice in your handout the term proctocolectomy. I want you to be sure you know that term as well. Procto means rectum, colo means colon, and ectomy means removal. So by definition of proctocolectomy means removal of the entire colon, rectum, anal canal, sphincters, anus, and permanent ileostomy. Now, the last thing I wanted to mention, we'll come back to this in our next class, is that a colostomy can be done at any point along the length of the colon. So you could have a C-costomy, an ascending colostomy, a transverse colostomy, a descending colostomy, or a sigmoid colostomy. And the location along the length of the colon does have implications for management. Go back to the whole purpose of the colon. Pull fluid out of the stool. Convert liquid stool to solid stool. And, sorry, we just had an interruption. So let me just go back. So the whole point is to pull fluid out of the stool and convert liquid stool to solid stool. The closer the stoma is to the small bowel, the more liquid the stool is going to be and the more frequent the output. The closer the stool is to the end of the colon, to the rectum, the more solid the stool is going to be and the less frequent the output. Also remember that there are differences in peristaltic patterns on the right side of the colon and the left side of the colon. That also has implications for management. We'll come back to this as well, but briefly, peristalsis on the right side of the colon is constant, pushing stool constantly toward the transverse colon. That means that if you have a patient with a C-costomy, an ascending colostomy, or a transverse colostomy, they'll have to wear a pouch at all times because output will be frequent and unpredictable. In contrast, peristalsis on the left side of the colon is intermittent, typically once or twice a day, occurring in response to enough distension at the level of the transverse colon to stimulate peristaltic activity. So that means a patient with a descending or sigmoid colostomy is going to have much less frequent output. And many of these patients are able to regulate bowel function by routinely instilling fluid from the stoma into the left side of the colon to stimulate peristalsis and evacuation. It's known as colostomy irrigation. We'll talk more about it. It's essentially giving yourself an enema through your stoma, washing out the bowel through the stoma to regulate output. Okay, thank you. We're going to stop there. When we start back, we'll be talking about management of the patient with a colostomy. Also, I want to just remind you once again, we will go over a lot of this during your bridge week. We will answer questions, hopefully do some demonstrations that will help you. But if you have any questions in the meantime, do not hesitate to call us or email us. Okay, thanks.